Hi, this is Brian Kim. I want to share with you case number 242 in the Best Way to Do Cataract Surgery series. And the title of this series is not to suggest this is the best way, but to get you to think about your best way that you can perform cataract surgery, which means thinking critically of your technique and constantly refining and honing your technique so that you can provide the very best for your patient. So this is the patient with a small pupil. You're going to see how I'm able to perform double chop, cross chop, and mechanically fracture the lens even though there's a small pupil without using any iris hooks or pupil expanding devices. And I'll be emulsifying only within this tiny central safe zone. And how I'm able to do this, I'm able to effectively crush the lens and crack the lens, and then using the chopper to hook the lens from the equator and pulling the lens pieces into the central safe zone with the chopper. And again, by doing it this way, I'm able to keep that phaco tip in the central safe zone and emulsify the lens pieces while depending upon the chopper to bring the lens pieces up to the central safe zone. So again, this is a small pupil. You can see that this patient has a little bit of a Bell's reflex. Seems like the left eye. I'm using a cotton tip to control the eye, and then I'm using a corneal marker which will help me to center and size the rexus. And then holding the eye and immobilizing it with the cotton tip, I make my paracentesis incision first on the right side and then the left side, making sure I'm parallel to iris plane, which creates a nice corneal shelf, which will allow me to achieve a self-sealing incision. This is intracameral epinephrine, and this is dispersive viscoelastic, which will coat the corneal endothelium and provide a little bit of visco dilation as well. Using the Orlock technique, twisting the cannula within the incision to hold it and to control the eye. And this is the triplanar corneal incision. I make a vertical groove, place the blade into the deep part of the groove, tunnel through the cornea, and then I enter. Again, holding the eye with the cannula with the Orlock technique, I'm able to turn the eye down, which is towards the left. And then I use my micro rexus forceps to puncture the center, pull down towards me, grabbing the right side of the tear, going around circumferentially. These micro forceps are really advantageous, gives me great control, minimal OFD egress, and I'm able to, again, perform a well-centered and sized rexus based upon the corneal mark that I made previously. Burping the viscoelastic out, and then I'm coating the cornea with the viscoelastic. And this is a capsule fornix hydrodissection technique. I place a cannula under the rexus edge contra-incisionally, point the tip down, try to get a wave. This patient obviously is moving a little bit, and that's a little bit of a problem, but that's okay. Do some more hydrodissection, decompressing the bag. But again, this patient, again, is under topical anesthesia and is having a little bit of trouble keeping the eye still, not quite following my commands, and it's moving the eye around a little bit. But you can see here now I'm able to spin the lens nice and easily here. Now that the cornea is coated, I do not like to irrigate the surface anymore. Lifting the incision, again, this patient's moving quite a bit. Lifting the incision with the chopper, going in with irrigation off to minimize Descemet's trauma. Again, the patient's moving really a lot, but now that I have two instruments, I'll have better control of the patient's eye. Staying in the central safe zone and not really being too aggressive with the fluid. Placing the chopper out under the rexus edge contra-incisionally, turning the phaco tip vertically sub-incisionally, fracturing the lens completely in half. Placing the chopper under the right heminucleus, hooking the peripheral lens and pulling it centered toward the phaco tip and fracturing the lens in half, and that is a cross chop. That is a double chop and cross chop respectively. Very carefully grabbing that first quadrant with some vacuum and lifting it up into the central safe zone and then emulsifying it. Loosening that second quadrant with the chopper. Getting under the rexus edge and then pulling that second quadrant up with the chopper, just mechanically hooking the lens and pulling it up. And then emulsifying the lens in the central safe zone. Again, in this case, I'm using the chopper to do all the work, bringing the lens pieces to the central safe zone, and then emulsifying it. Turning the second heminucleus in front of me very gently here, sliding the chopper under the rexus edge contra-incisionally, placing the phaco tip deep, fracturing that second heminucleus. Doesn't quite chop because I didn't get that chopper all the way out to the equator. And then now I do, and I fractured in half. There it goes. The key is to push down to make sure you're under the rexus edge when you're sliding the chopper out. Sliding the chopper out under the third quadrant, fracturing a little bit, but then using some vacuum to grab that third quadrant up, bring it into the central safe zone, and then emulsifying it. This is a fairly soft lens. I'd probably categorize this as a 1 to 2 plus dense lens. Nudging that last quadrant up, turning the phaco tip a little bit sideways, and then grabbing the lens piece with some vacuum, and then emulsifying the lens piece. Crushing the lens between the instruments and then emulsifying the lens pieces. Again, leveraging mechanical fracturing forces to crush the lens pieces into smaller pieces, and then emulsifying the lens pieces. Now that all the endonucleus is out, I'm just grabbing the epinuclear edge here, removing those lens pieces, and then on the right side you can see I'm trying to loosen it up with the chopper, placing the chopper over the epinucleus and then ushering it forward. I take the chopper out, push BSS in, take the phaco tip out, and I go in with the INA handpiece. There's a fragment at that paracentesis incision. And then I start subincisionally, trying to peel the cortex from anterior to posterior. Again, this is a small pupil, but so far it doesn't seem like an IFIS pupil. I'm able to very carefully peel the cortex from anterior to posterior, using foot pedal control to modulate, trying to grab the anterior aspect of the cortex, trying to peel it from front to back. And then switching to polish mode, polishing under the rexus edge. And the back looks fairly clean here. And in this case, I'm not pulsing BSS into the subincisional capsular fornix because the pupil is small, and I go straight with the cohesive viscoelastic. Burp some viscoelastic from the main wound. And this is the Bausch & Lomb LI61AO lens. This is through the small cartridge, guys. So when I go in and I push the plunger, the leading haptic may swing posteriorly, but that's okay. As the optic comes out, it flattens out. So again, you can see here the leading haptic is pointed down. But as the optic comes out, it's going to open up. And when the optic opens up, the leading haptic rights itself and it turns back into the proper orientation. Here it comes. Great. Advance the plunger all the way and then withdraw and then push again. And this causes the trailing haptic to go in and it bends on itself, and then you can deposit it into the capsular bag. Go in with irrigation off, activate irrigation. And anytime I have a small pupil, I always go in with the second instrument to make sure my haptics are in the proper orientation. I've seen, unfortunately, cases done by other surgeons, and I see them, for whatever reason, the patient may have moved to this part of the country or whatever, and I'll discover that one of the haptics is not in the bag. And that's not really ever a excuse. You should always be able to look, especially in this context when you have a small pupil, you should be able to visualize that both haptics are indeed within the bag. Obviously, if there's a big pupil, it's extremely unlikely that someone would intentionally leave one of the haptics in the sulcus. But in a small pupil like this, unless you check, you don't really know. And sometimes it's a single piece acrylic lens with one of the haptics in the sulcus. Sometimes it's a 3-piece. The point is you got to look at it. And so you saw you have a Maltzman second instrument, and I'm retracting the pupillar edge, making sure that both haptics are within the bag. And then with that second instrument, you can help tilt the lens, get underneath the lens, removing all the viscoelastic within the bag, controlling the pupil, making sure the iris doesn't come towards you. And it can act as a second instrument to help shield and protect the pupil as well. And then I remove all the viscoelastic and then I hydrate my incision. So again, this is a small pupil. And I was able to essentially perform double chop, cross chop, disassemble the lens into 3 pieces very efficiently using mechanical fracturing forces only. And because I utilize my instruments to crush the lens, I don't really need to see them exactly, so I don't have to use iris hooks or a pupil expansion device at all with those maneuvers. And then I rely on the chopper to pull the lens pieces up out of the bag, which is a very efficient way to do this. Of course, all of this is predicated upon proper technique. You need to make sure all your work and instrumentation and manipulation is within the capsular bag. It is not on top of the capsule. And so all of that means when you're placing those instruments out, you're pushing down slightly, you're making sure you can see the rexus edge, or you can at least see the cortical material. If you see that the cortical material is above you while you're sliding the chopper out, well, obviously if the cortical material is above you, that means you have to be within the capsular bag. So these are cues. Even though you have a small pupil, you might not see your rexus edge. Well, guess what? I can see the cortical material, the fluffy stuff. And if I push down with the chopper, pronating in my hand with the chopper, and I slide out to the equator, as long as I see that cortical material is above me, I know that I'm within the bag. So it's, again, a lot of experience. It's a lot of tactile forces and just knowing my way around the eye and around the capsular bag. And I'm able to efficiently and safely disassemble this 1 to 2 plus dense lens and injecting the Li601 AO lens, again, using a second instrument to retract the pupil to ensure proper placement. So I hope this was helpful to you, and I thank you for your attention.